preoperative evaluation of cardiac patients for non-cardiac surgery.
Okay.
Before going into the topic proper, I want to discuss some terminologies used in this topic, sir. First,
Mm.
the patient coming for a non-cardiac surgery, the surgery can be classified as immediate, urgent, time-sensitive, or elective. The immediate surgery is the surgery in where intervention should be performed without any delay, that is less than 6 hours for the preoperative evaluation. Urgent surgery is the surgery should be performed without any delay, but we have preoperative evaluation time is 6 to 24 hours. And time sensitive surgeries are should be performed as soon as possible, but uh, there is a time dependent risk of losing the limb or organ function, or there is an increased risk of complications. Example, mostly the oncological surgeries, and usually it is performed within 6 months. And the elective surgeries are a surgical intervention which can be performed electively, which can be delayed up to 1 year for the optimization of the patient. And patients, cardiac patients, have the risk factors like patient related risk factors and surgery related risk factors. The patient related risk factors are major factors, intermediate factors, and minor factors. The major factors are acute myocardial infarction, that is less than 7 days, or in recent MI 7 to 30 days, unstable or severe angina, that is class 3 and class 4, decompensated heart failure, worsening of new or onset heart failure, and dysarrhythmias like Mobitz type 2 block, third degree AV block, symptomatic ventricular arrhythmias, supraventricular arrhythmias, and symptomatic bradycardias. Intermediate factors are history of ischemic heart disease, history of congestive cardiac failure, history of stroke or transient ischemic attack, uh, insulin dependent diabetes, and serum creatinine more than 2 milligram percentage. The minor risk factors are family history of coronary artery disease, or uh, uncontrolled systemic hypertension, hypercholesterolemia, smoking, ECG abnormalities like arrhythmia, LVH, and bundle branch blocks, and post infarction, that is more than 3 months, and post CABG or PTCAs more than 3 months and less than 6 years, and symptoms of angina who are not on anti-anginal therapy. Regarding the surgery related risk, the surgery can be classified as low surgical risk surgeries, intermediate surgical risk surgeries, and high surgical risk surgeries. The low surgical risk surgeries contains the risk for major adverse cardiac events of 1%, and those are breast surgeries, dental surgeries, endocrine surgeries, eye surgeries, gynecological minor surgeries, orthopedic minor surgeries, superficial surgeries, and urological minor surgeries like TURP and VATS, minor lung resections. And intermediate surgical risks, which have 1 to 5.5 percentage of major adverse cardiac events, are carotid endarterectomy or carotid artery stenting, endovascular aortic aneurysm repair, head and neck surgeries, intraperitoneal surgeries like splenectomy, hiatal hernia repair, cholecystectomy, intrathoracic surgeries, and neurological or orthopedic major surgeries like hip and spine surgeries, peripheral arterial angioplasty, renal transplant, urological or gynecological major surgeries, and high risk surgeries which have more than 5% incidence of major adverse cardiac events are adrenal resection, aortic and major vascular surgeries, carotid, duodenal pancreatic surgeries, liver resection, bile duct surgery, esophagectomy, and open lower limb vascularization of acute limb ischemia or amputation, pneumonectomy, pulmonary or liver transplant, or repair of perforated bowels, total cystectomies. According to this risk, patient and surgery related risk, there are so many risk assessment criteria. The named criteria are Goldman criteria, Detsky criteria, Eagle criteria, Lee criteria, Gupta's perioperative risk calculator, revised cardiac risk index, surgical risk calculators, and surgical outcome risk tools. The most common we use is the revised cardiac risk index, which has 6 components, each having 1 point. The first point is a high risk surgery, that is intraperitoneal, intrathoracic, or suprainguinal vascular procedures, and all emergency surgeries. Ischemic heart diseases, history of congestive heart failure, history of cerebral vascular disease, insulin dependent diabetes, and serum creatinine more than 2 milligram per deciliters. And the risk of major cardiac adverse events are the term major adverse cardiac events include perioperative MI, heart failure, ventricular fibrillation, cardiac arrest, complete heart block, or cardiac death. The patients having revised cardiac risk index of 0 have 0.4 percentage of MACE, and incidence of 1% MACE in patients with 1 point, and 2.4 percentage of MACE with 2 points, and 5.4 percentage of MACE with 3 and more points. And patients who are coming for preoperative assessment, in history we take age, previous history of MI, previous history of congestive heart failure, and hypertension, history of diabetes, whether they are insulin dependent or oral hypoglycemics, history of valvular heart disease, and history of previous arrhythmias, uh, heart blocks, and bundle branch blocks, and other histories like smoking, hyperlipidemia, anemia, depression, and renal failure. In general examination, we examine the patient head to toe from height, weight, BMI, JVP, anemia, cyanosis, clubbing, period edema, and vital signs will be recorded. Blood pressure, heart rate, and pulse rate, which includes rate, rhythm, character, volume, delay, and we examine all peripheral pulses, and temperature and the respiratory rate. And in system-wise examination, CVS examination, we do inspection, palpation, auscultation, and other system examinations like RS and GAT examination and CNS examination to be done. Other than that, we do Duke's activity status index for the patient, which is the metabolic equivalence. The metabolic equivalence can be classified like MET score of 1 to 4. Patients who can do standard light home activities, walk around the house, and walk 1 to 2 blocks on the level ground at 3 to 5 kilometers per hour. And 5 to 9 MET score includes climbing of a flight of stairs, walking up a hill, walk on a ground at more than 6 kilometers per hour speed, run a short distance, moderate activities like dancing and mountain walk, and more than 10 METs include strenuous sports activities, swimming, tennis, bicycle, and heavy professional works. Patients with uh, MET score of 4 and less than 4 have poor functional capacity. And there are some class of recommendation according to the level of evidences. The class 1 is the procedure whose benefit is highly more than the risk of the procedure. And class 2 has class 2A and class 2B, in which the level of evidence for the benefit is more than the risk, and in such condition the treatment or procedure is reasonable to be performed. In level class 2B, the benefit is slightly more or equal to the risk. In such cases, the procedure or treatment may be considered. And in class 3, there is no benefit or harm recorded in the level of evidence. In such cases, the procedure or treatment should not be performed. Based on this, when a cardiac patient, especially ischemic heart disease patient, comes for non-cardiac surgery, we follow the following protocol. When a patient comes for the surgery, we consider whether it is emergency or elective. If it is an emergency, we do clinical risk satisfaction and we proceed to the surgery. If it is an elective surgery, we evaluate the patient for the acute coronary syndrome. If yes, the patient to be evaluated further and treated according to the guidelines. If the patient does not have acute coronary syndrome, then the risk assessment according to the MACE incidence and the patient's risk factors to be considered. If it is a low risk surgery with MACE less than 1%, no further testing can be to be done and it can be proceeded with the surgery. And if the MET score is more than 4, if the function capacity is good, uh, no further testing is needed and surgery can be proceeded. If the MET score is less than 4 or the functional status of the patient is unknown, we go for further investigations for decision making, like ECG and echo. If there is any positive finding, we go for stress test and we evaluate the patient. If there is no positive finding, no further testing is needed and we proceed with the surgery. If the stress test is positive, we go for further invasive tests like angio and coronary revascularization is to be considered. If the test is normal, and we can proceed with the surgery. And for the recommendations, AHR recommendations for ECG is routine ECG is reasonable for patients with known coronary artery disease and other structural heart disease, except in the low risk surgery. It may be considered for asymptomatic patients undergoing moderate to high risk surgery. And ECG is not useful for asymptomatic patients undergoing low risk surgical procedures. And regarding the exercise ECG, if the ECG shows any abnormality or there is patient is asymptomatic with doubtful values or doubtful functional capacities or the functional capacity could not be assessed, we go for further stress test or stress echocardiography with dopamine like dopamine stress echoes and other tests like uh, cardiopulmonary exercise testing. The alternative examination for cardiopulmonary exercise testing is 6-minute shuttle walk test or shuttle walk test, which can be performed in the emergency, or the further invasive angiography, CT angiography or coronary angiography, invasive angiography can be considered. Considering angina, the angina can be classified according to New York Heart Association as class 1, no limitation of physical activity, and class 2, slight limitation of physical activity, ordinary activity resulting in fatigue, palpitations or syncope, and class 3, marked limitation of physical activity less than ordinary activity resulting in the fatigue, in palpitation or syncope. Class 4, inability to do any physical activity without discomfort and patient is symptomatic at the rest. And coronary revascularization to be considered. Coronary revascularization be either PTCA or bypass grafting. It can be considered in patients with unstable angina or MI, which is life-threatening, and life-threatening arrhythmias due to active ischemias. And PTCS can be divided into 3: balloon angioplasty, bare metal stent, and drug-eluting stents. Patients undergoing PCIs balloon angioplasty should wait for 14 days for their elective surgeries, and patients who are having bare metal stents should wait for 30 days for their elective surgeries, and who are having drug-eluting stents, the optimal time period is 6 months. The patient will be on dual antiplatelet therapy for 1 year for drug-eluting stents. And for bypass grafting, the bypass grafting is indicated in the left main disease and who are having ejection fraction of less than 20%. The gap between time sensitive surgery and CABG is 4 to 6 weeks, and the waiting period is 6 months for elective surgeries. Regarding the preoperative medications, the patients on dual antiplatelet therapy, the aspirin to be continued till the day of surgery, and the clopidogrel should be stopped before 5 days before the surgeries, and other
Hello?
rivaroxaban 7 days before surgery, clopidogrel 7 days before surgery, ticlopidin 14 days before surgery, prasugrel 7 to 10 days before surgery, ticagrelor 5 days before surgery, apixalimab 48 hours before surgery, and tirofiban 8 hours before surgery. And regarding perioperative beta blockers, the perioperative beta blockers can be started for immediate or high risk patients, and those are having revised cardiac index more than 3. Preoperative beta blockers were indicated, it should be started well before the the tolerable status of the patient.
Problem with your audio.
Antioxidant properties, improved endothelial function, and increased nitric oxide availability. The perioperative period, those patients who are on chronic statin therapy, the statins to be continued. And continuation of the ACE inhibitors and ARBs are to be withheld. It to be continued in the perioperative period. If withheld prior to surgery, it should be restarted as soon as possible. Regarding the valvular heart diseases, patients who are having established known valvular heart diseases, and on clinical examinations, patients having diastolic murmurs, continuous murmurs, or late systolic murmurs, murmurs with ejection clicks, patient should be evaluated with echocardiography and chest radiograph, and the severity of the valvular disease should be assessed. If the severity is more, and surgery is elective, adequate optimization to be considered. And infective endocarditis prophylaxis to be considered in patients with previous history of infective endocarditis, congenital heart disease with unrepaired cyanotic congenital heart disease, including palliative shunts and conduits, completely repaired congenital heart defects with prosthetic material or devices, and during the first 6 months after the procedure, and repaired congenital heart diseases with residual defects at the site or adjacent to the site of the prosthetic patch or the prosthetic device, and cardiac valvulopathy that develops in the cardiac transplantation recipients, and the surgeries which are which has a high possibility of bacteremia after the surgery. The infective endocarditis prophylaxis is either oral or IV. Oral medication is amoxicillin 2 grams in the adults, or who are unable to oral medication, ampicillin 2 gram IM or IV, or cefazolin ceftriaxone 1 gram or IV can be given. In the patients who are allergic to ampicillin or penicillin resistance, cefalexin, clindamycin, or azithromycin can be considered. An IV injection of cefazolin or ceftriaxone 1 gram IM or IV can be given. Regarding patients who are having pacemakers, patients who having dysrhythmias in the ECG should be optimized with either beta blocker or antiarrhythmics, or in cardiovascular implantable devices are indicated. Patients with cardiovascular implantable electronic devices are to be managed in a team. There should be a surgical team and a cardiac implantable electronic devices team. The surgical team should inform the pacemaker team regarding the type of procedure, anatomic site of the procedure, patient positioning, whether electrocautery will be used or not, and other details such as large blood loss during surgeries. And the pacemaker team will inform the surgical team regarding the type of device, indication of the device, and the programming of the device after proper pacemaker interrogation, like pacing mode, rate responsiveness, and the battery status of the implantable devices, and the whether patient is pacemaker dependent or independent, and the magnet response of the pacemaker. Routine inactivation of the pacemaker is not indicated in all the procedures. The asynchronous mode is uh, generally indicated in surgeries which are above the umbilicus, and where the electrocautery or radiofrequency ablation is used. Thank you, sir.
Okay, very good. But the question is actually uh, evaluation of a cardiac patient for non-cardiac surgery. So the common cardiac diseases with which a person may come for an incidental surgery, which is not aimed at correcting the cardiac defect. Commonly, we come across ischemic heart disease. The next common thing is valvular heart disease. And the third common condition is life-threatening arrhythmias. And to this, some books also add cardiomyopathies. Hypertension per se is not included in the cardiac diseases because it is more of a vascular problem. So these four conditions are actually taken up as uh, cardiac diseases for which when a patient comes for an incidental surgery like a hernia or a C or a fracture or an abdominal cholecystectomy, then you have to know how you are going to evaluate him and make him see whether he is going to be fit for the proposed surgery. You very correctly started off saying that the first and foremost thing we have to take into consideration is the urgency or the nature of the surgery, whether it is required emergency or urgently or time selection, or you have some time to prepare the patient, or completely elective, which can be done at leisure after correcting the cardiac defect. These four categories are there. And of course, there is no doubt that if it is an emergency surgery, like say a traffic accident, multiple injuries, or a perforation, or a valvulus, or an acute appendicitis, all these life-threatening emergencies, you have to take up the case. Otherwise, the patient may die of the surgical complication itself. So there is no question of refusing the patient because he has a cardiac ailment. But the degree of monitoring with more invasive and aggressive monitoring and good postoperative care in a high dependency unit to manage all the complications that may arise because of the existing cardiac disease is is what we routinely have to do. So there is no question of trying to evaluate the patient. You explain the risk and then take up the patient, but with all the facilities, as far as possible, try to manage him to the best of your ability. But the other categories of patients are the ones who may be optimized a little bit more. So for that, you have to assess what is the degree of risk involved in them and then try to optimize them as much as possible, which of course you explained in much detail. So just to supplement, you have mentioned most of the points, but I think so much detail about the types of surgeries to be performed can be cut down, because in a theory exam, when you write, if you write 1.5 pages about the various surgeries that have to be taken into consideration, that itself will be time consuming and you cannot complete your answer. So you can just mention surgeries which are mild risk, moderate risk, or intermediate risk and high risk surgeries. And just an example, one or two, you can just mention and finish off there instead of writing too much details about the nature of
Okay, sir.
surgeries that are performed. And
Okay.
also optimization, you can just cut down on that. Like what are all the important drugs that have to be continued and what drugs have to be stopped. If you mention that, that will be more than enough instead of individually mentioning each drug with their time duration and all that. And otherwise, that is a very fairly exhaustive answer that you have prepared. Anyway, I will just try to make it little more easy for you to remember by a question and answer type of presentation, where we easy. Uh, so perioperative cardiovascular assessment of patients undergoing non-cardiac surgery. The first question is, what are the cardiac diseases commonly encountered? So that you have to first know. The common cardiac conditions are ischemic heart disease, congestive cardiac failure, valvular heart diseases, arrhythmias, and cardiomyopathies. These are the 5 common cardiac conditions for which a patient may come for an incidental surgery. Now, what is the severity of the heart disease? Once you know the patient has a heart disease, the first thing we would like to know is how severe the heart disease is. Is it mild, moderate, or severe? Whether it is compensated or decompensated. That is the answer that we want to get. Now, my next question, what is the nature of the surgery that the patient is coming to? It is a high risk surgery, moderate risk surgery, or low risk surgery. And you can give one or two examples for all these things. And what is the timing of surgery? This is what you started off first. So, what is the timing of surgery? Whether it is emergent, urgent, time specific, or elective. These are the 4 categories. So if it is an emergency surgery, there is no question of asking any more questions. Straight away you proceed. So, and what are all the pre-op investigation needed to assess these patients? Whether you need an ECG or echo or stress test or blood test for BNP or troponin because of the conditions. These are all the things that you should next know. Now, what is the functional status of the patient? What is the METs for the patient? Duke's activity index. These things will tell you the functional status. And once you know all these points that you want to know from the patient, what is the type of cardiac disease, what is the severity of the cardiac disease, what is the nature of surgery is going to undergo, what is the whether it is urgent or emergent or elective. So, by if you know the answer for all the first 6 questions, then the seventh is to assess the risk, for which you use the risk assessment score like RCRA, NSQI, MICA, and then you also find out what are the current drug therapy he is on and whether you need to do any modification on that, like beta blockers. Beta blockers, you mentioned that it should be started well before advance. So they found that patients with ischemic heart disease don't just start beta blockers, especially the vascular surgeons when they post a patient for, say, iliofemoral bypass or iliofemoral bypass, then they try to start the patient on beta blockers even if they don't have ischemic heart disease, thinking that it will reduce the post-op mortality. But if a beta blocker is started just 1 or 2 days prior to surgery, it causes more problems. Whereas if it should be started at least 2 weeks prior to the surgery. That is the deadline that they are now prescribing. And even after giving beta blocker in a prophylactic manner, they have found the death due to stroke is more rather than myocardial incident, major cardiac events. So beta blocker, if the patient is already taking beta blocker for a long time, it should not be stopped, it should be continued. But de novo cases don't start in a very acute phase, at least give it 2 weeks prior to the start of the surgery. And statins also have the same rule. If the patient is already on statins, you must continue that and don't start statins just 1 or 2 days prior to surgery. And AC and ARBs, because of intraoperative hypotension, we prefer to stop it. Antiplatelets and antiarrhythmics, you must antiplatelets, you must weigh the pros and cons of thrombus formation like PE or deep vein thrombosis. And if already there is a history of thrombus anywhere in the body, better to continue them and manage the bleeding intraoperatively with other substitutes rather than stopping these drugs. Similarly, antiarrhythmics also, you must try to keep the patient as much as possible in sinus rhythm with continuing the antiarrhythmic agents. And any interventional procedures are required before the planned surgery, like you said about PTCA or bypass or other interventions or pacemaker insertion. All these things have to be planned well before surgery. And you have to take into consideration the level of evidence and the class of recommendations for each and every suggestions that you give, whether to go ahead with the PCI or CABG or pacemaker. And once these 10 questions are answered, your most of the evaluation will be finished. But there is an algorithm or a stepwise method that is given in many of the books, which also you have to write in the exam answer. So step one, risk stratification comes there, whether it is an emergency surgery, clinical assessment, and proceed to surgery. Non-elective, proceed to step two. And step two, first you rule out any acute coronary syndrome. The patient has acute coronary syndrome, otherwise which is called the IHT, treat according to published guidelines. And if there is evidence of ACS, proceed to step three. Proceed to step three is major adverse cardiac events. Low risk, less than 1%, proceed with surgery. Elevated risk, you go to step four. Step four is the functional assessment capacity. What is a match with more than four, proceed to surgery, less than four, further testing. And step five is stress testing. This is mainly with an aim in ACS. It is not covering anything about the valvular heart disease or your arrhythmias or your cardiomyopathies. So this is mainly a evaluation for patient with IHT. So here this is what is mentioned about the class of uh, recommendation and level of evidence. This is sometimes asked as a short notes. So I just thought I will just give this picture. So class 1 is definitely the benefit is more than the risk, 3 times more than the risk. In class 2A, the benefit is only twice with the risk, and class 2B, the benefit is almost equal or slightly more than the risk, and class 3 is there is no benefit at all or there is more harm. So if you find any evidence which is class 3, recommendation which is class 3, that is a very harmful one, whereas the class 1 and class 2A are acceptable. And for that you have a lot of reference, and level A evidence is multiple population evaluated, that carries more weight, and level B, level C are all less studied and analyzed. So a class 1 or a class 2B recommendation with a level A evidence will be the ideal condition for most of the patients. So if you get that, then straight away proceed with the surgery and uh, take up the patient for surgery. So with that, I think all the other points she has mentioned correctly, and so that will just